Hello and good afternoon, everyone, and welcome to this webinar this fine afternoon. We see some people are still joining, but let's get ahead and start the discussion as we have quite a packed agenda for you today. So before we go into the webinar proper, I just wanted to mention that we very much want this to be an interactive discussion. And as I'm sure many of you, like me, have sat through a lot of webinar and you have a lot of questions and comments. So of course, feel free to make use of the chat function. Feel free to write your questions and comments in the chat, and we will get to those throughout the webinar and also towards the end. We have set aside some time for discussion as well. The purpose of this webinar is for you to get to know us as a coalition and to learn about comprehensive genomic profiling and what it is and why it matters for patients. And so, of course, please bring your questions and any comments throughout this hour. And of course, if you want to learn more about us, you can visit our webpage. We are also on social media, on Blue Sky these days, and on LinkedIn, where you can really follow updates from the coalition. Also, I should mention that this webinar is being recorded, so if for some reason you are uncomfortable with that, just be aware that it is being recorded. So in that case, if you're not okay, you might want to not partake in the webinar. So here's the agenda for today. I'm sure you have already seen it, but we'll start with a bit of a brief introduction to the coalition, who we are, what we are trying to do, and actually why we are here. I see we have an AI assistant these days. There's a lot of AI and artificial participants also in the webinar. That's great. And then we will be kicking over to our great speaker, Professor Albrecht Stenzinger from the University Hospital of Heidelberg, who is also a member of the ECGP steering group, and he'll be speaking a bit about what CGP is, really, because I think this is quite new to many of you, and what is the benefits of CGP? Why should we care about this? And a bit the untapped potential if we look towards the future as well. And then we'll be bringing in, one more of our steering group members, Antonella Cardone, who's the CEO of Cancer Patients Europe. And here, Antonella, myself, and Albrecht will be covering some of the recommendations that ECGP has been putting forward this year. Unfortunately, one of our speakers, Professor Paul Hoffman from Côte d'Azur University in France, he was not able to make it due to a rebooked flight, unfortunately, so he could not be here with us today, but he sends his apologies, and I know he very much wishes that he could have been here for this conversation. And then Albrecht will be speaking a bit about some best practices, because CGP, it's not just a new thing which is on the horizon. It's also something that is already in use and being used as well at national level. And Albrecht will be sharing a bit about how that is now being implemented in Germany. And then, of course, we'll be opening it up to you, the audience, to bring in your perspectives, questions, and comments. And with me today, also, I should say a huge thanks to my colleague Milana, who has been helping to organize the webinar as well. She's with me here in the room, and she'll also be following your questions and comments throughout the webinar as well, so to make sure that you're also involved. So with that, I'm very happy to start off with just a very quick overview of the coalition and who we are. And probably the reason why you're even following this webinar in the first place is because you, for some reason, are interested in personalized therapies and personalized medicine. So it might not be news to you, but I mean, this is really a change that we are seeing in the way that drugs are being developed and the way that drugs are being delivered to patients based on really this growing understanding of the molecular drivers of disease. And of course, now there's with biomarkers and these genomically matched therapies that can be delivered to patients. This is really revolutionizing our approach to cancer care and cancer treatment, whereas previously you would talk about a sort of like a trial and error approach to healthcare, where all patients would be given a chemotherapy. Now, based on our growing understanding of the genetic drivers of cancer, with several hundreds of genes being tied to cancer growth, really we can develop and really offer personalized therapies for patients. And of course, this is a great opportunity, but it also presents some challenges for our healthcare systems as well. We also see that there's a huge political momentum right now in Europe, driven by the Europe Screening Cancer Plan. And in the cancer plan, there was really a commitment, a strong political commitment, I believe, and the language was something like leaving no stone unturned to take action against cancer. And there was a long time since we had such a plan, an action plan at the EU level to address cancer. And this cancer plan, of course, goes across the spectrum of cancer care, from really prevention to follow-up of cancer survivors, and diagnostics is a part of this as well. And I think this is something to of course be aware of. And so with this in mind, with these changes that are happening and this new political momentum, we saw that there's a need for a coalition, an organization that can really speak on behalf of what is needed to take advantage of this development in molecular diagnostics in order to deliver these targeted therapies to patients. And so this coalition has been set up with the support of EUCOPE, the trade association, and all of our member companies, which you can see under here. And these are both diagnostic companies that develop the diagnostic solutions, and also pharmaceutical companies that develop targeted treatments for patients in cancer and also rare disease. So what is really the situation? I mean, if we and this was a bit of a seminal paper. I think many are already familiar with it by Romano in 2022. So it's already a few years old, but this is really gives a good overview of where we are at with access to genomic testing in Europe today. I'm seeing we have some issues with the audio. Perhaps you can try and leave and reconnect. I think the audio should be working. We did test this already. So if you leave and connect or try a new browser, then maybe it should be working for you. This is strange. We'll have the team check that. Thank you for letting us know. Okay, so seems some people it's working, for some not. So maybe try to rejoin. And you can also do it by your browser. I think maybe we have the option to dial in as well. Maybe Milano, you can provide the phone number if that's an option. So if we look across Europe today, I mean, there is good access when it comes to genomic testing. This is improving. It is good access, and it was rated as high when it comes to this single biomarker test access. However, when the same study was looking at the access to multi-biomarker tests, where it tests for several possible mutations or genes within a single test, you immediately see that a lot of these countries that were previously green or orange are now falling into the red or the orange category. So the situation is a lot worse. And we also see that in some countries where they have very regionalized healthcare systems, such as in Spain and Italy, there's this really a huge variation, even within the countries. You could come from the same country, and then you might not have access to the same types of testing, depending on which region you are from. And of course, the big difference here, and one thing to note, is that really, when it comes to providing access to single gene testing, this says we have made headway, but then when it comes to this multi-biomarker testing, we still have ways to go. And of course, this is very complex, because if you think about personalized medicine, if you think about diagnostics, if you think about implementing this cancer care, there's a lot of pieces that need to be in place, and there's a lot of stakeholders that need to move together here. I mean, everyone from the patients to the transformation of the healthcare system, industry, healthcare professionals, payers that have to take important decisions about what to pay for and what to reimburse and what not to reimburse. I mean, it really needs all of the stakeholders to have a shared understanding of what the problem is, and to come together across some solutions in order to address this. And this is really why ECGP has been set up to really raise awareness on the role of comprehensive genomic profiling, and we'll get into that in a minute, to gather some of the existing evidence, some of the emerging evidence which is there already on the economic and operational evidence and the value of CGP to really help inform payers and decision makers on the decision on whether to go ahead and fund and reimburse this. And and also with then changing the pricing reimbursement frameworks. And of course, this coalition is not operating in a vacuum. We're also collaborating with other coalitions as well. So a bit about the structure of this coalition. So it is governed by a steering group, which is at the EU level, because the focus of this coalition is Europe. And I would say, and we're very happy to have two of the steering group members with us here today, so you get to meet them. This idea is really to have a group where we can exchange and promote some of these best practices of CGP, where it is already being implemented, and have some lessons for those that are perhaps a bit later in adopting it. But I would say, all in all, and that everyone is still a bit learning how to implement this, and I think there's some best practices. There's no one solution for all yet, and of course, there are large differences between healthcare systems, and that's why we also have established some national ECGP chapters. If you look at those two countries where there were some large regional variations in Italy and in Spain, here we have started two chapters where we bring together some of the local decision makers, some of the local stakeholders, and work together to try to address some of these challenges in Italy and Spain. These projects have already kicked off, and we've had some of the first meetings in Italy last week. Here's the great steering group members who are dedicating their times and efforts to this. Of course, you can look these up as well online on our website, and all of them really knowledgeable about the topic and also involved in implementing CGP within their countries. And as you can see, we try to have a good mix of the different stakeholders, to have patients, clinicians, healthcare professionals, and also together with this mix of different types of industries as well that are involved in delivering this around the same table to find joint solutions. That's a bit about the coalition. Milan, I don't know if we already have some questions in the chat. I don't think so, and I think some people are able to fix their audio, so that's working now. So that's really great. Albrecht, then I believe we are ready to hand over to you if you are still there. I think you went off camera.
I'm still there. Yeah, happy to take over, and thank you for the wonderful segue. Yeah, it has been a pleasure to working with my colleagues to identify points that we still need to address, but also to identify what is already there. In my personal view, it is very important to realize that, as has been mentioned previously, we still have quite some heterogeneity throughout Europe regarding testing or biomarker testing in general. And that, I think, is of some concern, given that, for example, EMA is approving a certain drug, but the question of one, whether the drug is available in a certain country, and second, whether appropriate and required testing is reimbursed, is very much dependent on the health tech assessment bodies within the countries of the European Union, and that can greatly differ. And I think that very much contributes to the heterogeneity that you nicely pointed out. And I think there is also a great study from Bale and colleagues driven also by ESMO that confirms what Nicolas has found as well. So that broad heterogeneity on a country level, but even within a country, really needs to be addressed, and democratizing approach or democratizing the access towards clinically meaningful biomarker testing is really something that we as a community need to work on. And I think a stakeholder integration is therefore very essential. So it is not only about the diagnostics people like the pathologist, medical geneticist, and so on, but this is also about integrating, government agencies, payers, academia, healthcare, patient advocacy groups, and others to really drive that forward. And that does not mean to offer, profiling that is not clinically meaningful, but providing the breadth of profiling that is really important and matters to patients. Now, many of these biomarkers are interrogated at a genetic level. Many of them being somatic events, somatic driver mutations. And I think for biliary tract and also lung cancer, it becomes apparent that broader molecular testing is very much required in a clinical context, simply because it is more than just one target that you would like to identify. And you could potentially try to identify those by sequential individual gene analysis. But this is inefficient in several ways. One, economically inefficient, and second, inefficient in terms of the tissue that is actually required, because tissue is sparse and very precious, and therefore, oftentimes sequential testing approach wouldn't work. And the third aspect is that lung cancer being an example, you need to, as a clinician, you need to have all the information available at once at a certain disease stage, in this case, stage 4 lung cancer. And therefore, genomic profiling that goes beyond individual testing, individual gene testing, really is of importance. That obviously is something that is evolving with new evidence evolving. I think this tight interaction is very critical. So new clinical trials, new scientific data leading to a meaningful extension of the genomic profiling that is clinically required. We already touched on non-small cell lung cancer. Another, patient group that is very much neglected, but certainly can benefit, as has been shown in a recent clinical trial, from targeted treatment are patients with cancers of unknown primary, meaning patients who present early on with metastatic disease and the underlying primary cancer is not known. That is a very devastating disease, and comprehensive profiling can help here in two regards. One, identification of drug targets, and second, it may also help to actually identify the underlying primary. So for example, a fully differentiated adenocarcinoma in a cancer of unknown primary setting, where you would identify, for example, an EML4 ALK gene fusion, probably leads us to the underlying primary of a non-small cell lung cancer. And an FGFR2 gene fusion in the same context may point us towards considering intrahepatic cholangiocarcinoma. And then obviously there are, other patient groups that could potentially benefit as evidence is accumulating. The recent ESMO guidelines that have been issued on multi-gene testing for patients with advanced cancer now recognizes a number of different cancer types where comprehensive multi-gene profiling really matters and has clinical impact. Very, very importantly, we discussed this already, sequential testing approach is very time consuming. It's economically not efficient, and it may exhaust tissue so that certain analyses are not even possible anymore. And therefore, a one-stop shop, broad comprehensive testing, if chosen carefully, can provide insights that are clinically very, very meaningful.
Albrecht, I want to bring in, thank you so much for this. I mean, this is a very comprehensive overview of let's say, a bit what is it that CGP is bringing that is different, right? And then the current single gene testing that is being offered. But Antonella, I want to bring in a bit your perspective here, because I mean, talking from a patient's perspective, what are some of the benefits you see with having, the access to a single test that is covering a lot of these possible mutations within a single test? Of course, with Albrecht talks about wasting tissue samples and avoiding repeat tests. That there's not only an economic costs associated with that, but there's also, let's say, a burden for patients as well.
Yeah, absolutely.
Maybe Antonella first, and I'll bet you can make
it. Please.
Yes. Yeah, thanks, Matias, for the question. So I'm Antonella Cardone. I am the CEO of Cancer Patients Europe, and Cancer Patients Europe is the pan-European all cancer types patient organization. We are very much interested in the value that CGP brings to the patients, and I can say that the CGP brings value to patients as it allows early identification of the targeted treatment best suitable for them. It reduces unnecessary risk of side effect due to a treatment that won't add any benefit possibly. And it also brings value to future patients as it enables rapid knowledge development through the rapid implementation of a database with relevant information. And also the CGP brings value to the healthcare systems as it provides substantial clinical benefits and improves patients' outcomes with a minor additional investment, not cost. I mean, I really like to mention that CGP do not come with additional cost to the system, and it brings value to the society as a whole as patients receive the most appropriate treatment promptly without wasting unnecessary time of work, both for patients and caregivers. So we needed to really look into the indirect costs of non-using CGPs when delivering, when trying to get the right diagnosis.
That's a very interesting point that you make, Antonella. And we have there's a quote here from one of the other steering group members, right? And it says that it's from Professor Mark Laurie of the Queen's University of Belfast. It says that rather than the costs of genomic profiling, we should focus on the cost of not profiling. And that's a bit what you're saying as well, is that maybe sometimes we don't have like a full good overview of what are the actual costs when we think about the benefits of such new technologies as well. Maybe we're not thinking about the wider impact here. Albrecht, what do you see as some of the main benefits for the healthcare systems in these quicker turnaround times? Are there cost savings there? Are there other benefits as well for the healthcare systems and moving towards comprehensive genomic profiling?
Yeah, great points that have been made. I think, one aspect certainly is that a learning healthcare system is probably very important. So we used to silo healthcare systems in a way that they offer certain services, but without really associating them with a deeper gain of knowledge. And for example, patients being treated at a hospital with a certain number of different drugs or drug target matches that have been identified. And then the question may arise, how did these patients actually benefit? And I think registries can greatly help in this context and could also complement, classic clinical trials, not replacing them. They are very much needed, but complementing them so that, these two areas interact with each other. And I think that very much drives forward knowledge, but it also helps a given country to build an ecosystem that goes way beyond the individual patient. In a daily clinical context, I would say when it is appropriate, one-stop shop broad test helps to identify, if we are talking about large panel up to, interrogates up to 500 genes, sometimes a little bit more, sometimes a little bit less, with a turnaround time of, 10, maybe 15 working days or so. Meaning turnaround time from receiving the material to issuing the report, and that greatly helps to avoid therapies that may be not necessary, and it also may help, as I mentioned, to render the correct diagnosis, or at least support a certain diagnosis. And we are using CGP in this context as well. So it's not only about the identification of drug targets, but really even beyond that.
And I think this is a great point to make, right? Because it might not, CGP, then it might lead to a decision that you should not have a specific treatment, and then there's also or that you don't go for chemotherapy, and then you try something else, and so you don't go through these several stages of trying different treatments that don't work, but you go directly for the correct treatment. I know we like to talk about giving the right treatment to the right patient at the right time, and it's all about tailoring that the treatment regimen, so it's not necessarily a therapy, but the treatment of that patient based on that increased understanding. And I think also, as you said, Antonella, it's all about the time that it takes there as well. So Albrecht, when you say 10 to 15 working days, I mean that's quite a quick turnaround time. But you can imagine then if you have to go for an individual test that goes through those couple of days, it comes back. Wasn't that? Do we test for something else? I mean, then you're losing a lot of time, and the cancer keeps growing, and of course that does not lead to better outcomes. It leads to worse outcomes. I think we have a question already from one of the audience members. We want to bring this in. It's from Doug Niven. He asks, given the broad benefits of CGP, are payers reimbursing these tests broadly? If not, for which uses are they not being paid for? And I think it's fair to say, I mean, Albrecht, Antonella, feel free to come in. I think it's fair to say at this point, it's not broadly reimbursed. It's a bit the reason why we're existing here. If you looked at those first slides, I mean, when it comes to these broader tests, the access is not as widespread as it is for these smaller single gene tests. So what do you think is the reason for that? Is it that this is a bit more there's more uncertainties around the value of testing for a lot of genes? Do you think that this evidence, there's some lag time between, you know, when a new technology comes and when the evidence is being developed? Or can you speak perhaps to this question from that?
Yeah, I think it's probably a multifaceted view that we have to take here. One major structural component is certainly that you have, on the one hand, an agency, EMA in this case, which approves a certain drug or drug target combination. And on the other hand, you have health tech assessment bodies, HTA bodies, in each of the different member states of the European Union. And these HTAs are primarily responsible to validate and evaluate the approval from EMA and decide whether and to which extent a certain drug plus possibly the associated test will be reimbursed in country XYZ. Sometimes, however, the HTA body does not even decide on this issue, but leaves that to other agencies within the country. That is one aspect. The other aspect is that the healthcare budget is always national, right? So it is not the EU that decides on the overall budget of the EU member states. And so it is up to the individual member states to decide to which extent money is invested in the healthcare sector in specific areas. And the third point probably is that even within a country, so given that there is some, basic understanding on reimbursement, there may be regional differences where a certain, amount of money is designated to a certain region and they can use the money in a certain way. Whereas another region receives less and decides differently on how they are using this money. So I think these points largely contribute to the heterogeneity of reimbursement. The second or the other major part is certainly around the question of education and a better understanding of what molecular testing or biomarker testing is good for, and where it can actually help and support. So these are maybe the major points. And lastly, especially when we are talking about broader genomic profiling, I think it's fair to say that this is kind of a, platform economy where the higher the volume becomes, the more, costs are decreasing. And that, I think, is another aspect to take into consideration. And associated with that, I also firmly believe that costs, meaning the money we have to take in to purchase actually instruments and kits and so on. That these costs also have to decrease over time in order to really democratize that, because no one would probably talk about reimbursement issues if something like comprehensive genomic profiling would be something like the new PCR, cheap, easy to use, fast and reliable method as a clinical grade test. And we are not there yet in terms of this cost issue, but I'm very certain that eventually we are getting to this level, and then we're going to have way broader outreach. And the question of reimbursement is probably something that is, more or less pronounced as it is now.
Yeah. Thank you. It's very, it's a very complex situation, and thank you for not giving a very simplified answer, but really touching on multiple things that are contributing to this, and I think it goes a bit back to when we were talking about the costs, right? And what was also mentioned by Antonella is that maybe sometimes we need to think of it not as just as a cost, but also as an investment as well, right? That this is something that we are building for the future as well. I want to also maybe touch a bit on and because this was mentioned, right? And yeah, we have a nice quote from you here as well from the paper, and you mentioned this briefly, right? That what are the benefits for research as well of doing this larger scale test? Because when this data then is captured also in registries, we have now the European Health Database, which is going to be implemented, and from I think 2031, if I'm not mistaken, we will have also a secondary use also of genomic data. So of course, the more we sequence, the more data that is captured by the healthcare system. That is also data that can be used for research and development of future therapies as well. So and I think you briefly touched upon that. There is a bit of let's say some benefits beyond just the immediate benefit of correct treatment for these individual patients, but there are also benefits as well for the healthcare systems and wider society. And of course, also with better outcomes, Antonella touched on this, you can also have the ability to return to work earlier. There's less of a burden on carers, and I think this is, of course, important to keep in mind as well. And hopefully, with the European Health Database, we can better capture some of these points as well and make more informed decisions as well going into the future. I think is Antonella is still here. Perhaps she had a bit of an issue with the Microsoft Teams. So I'm sure she will rejoin us in 1 second. But let's maybe go again to let's see if there are any questions or any comments from the audience. Feel free to put that in the chat or to raise your hand. If not, let's maybe go over the recommendations. So ECGP has, as a coalition, we've just put forward our first recommendations, which touch on a lot of what you just heard from Albrecht and Antonella. And you probably heard, okay, well, this sounds very complex. There's a lot of issues, there are a lot of challenges, but we are here to try to identify some solutions which can actually address this. So why don't we speak about a few of these recommendations? And as we're waiting for Antonella to reconnect, why don't we look a bit at what we call recommendations 3 and recommendations 4? I mean, Albrecht, when it comes to the implementation, you mentioned that there's been some inclusion in ESMO guidelines of CGP, and of course this also needs to be driven by implementing right standards and also investing in the European Health Database was mentioned. So how's this? What is the role of this supporting infrastructure in supporting CGP uptake? You mentioned briefly that the registries. Do you want to expand a bit on this?
Yeah, that's a great point. Thank you. Yeah, I concur with you, and probably we are currently underappreciating the structural environment that is needed. So you might think that if you buy a certain sequencing device and maybe hire someone who is able to run the sequencing device, you are almost there. But that's not the case. The IT infrastructure, for example, that is required for thorough comprehensive testing is growing along, and that is often neglected or not well understood. The other structural point is that depending on the clinical case scenario, cases require discussion in a molecular tumor board, which is again a multi-stakeholder interdisciplinary team effort that also not only requires the various disciplines ranging from medical geneticists, pathologists, oncologists, radiologists, and so on and so forth, but also includes a coordinating role. For example, it requires a database infrastructure. It requires tools that may help to rank certain variants that you may identify, and then issue some guidance or recommendations in terms of therapy. So that is another structural point. And if we are think about, low prevalence genetic events where it certainly makes a lot of sense to share data across borders between, for example, France and Germany, or Germany and Poland, or the Netherlands and Austria, really becomes critical, and very often these siloed approaches within and across healthcare systems prevent a lot of data collection and ultimately generating evidence. So the structural component is really a key part that is often overlooked. And also think about, if you collect data, let's assume that you have a legal environment in which you can do so. Let's assume that for a second, if you were to collect data and share data between different nations within the European Union, you would have to make sure that data are standardized and of similar high quality. And that starts with the genetic part, but doesn't end there, but would also include the way, the follow-up from a clinical perspective has been done, the parameters that have been collected, time points, and so on and so forth. And that, again, points towards structural environments that are very critical. And lastly, if you think about, sharing data, that also means that we really need to have a digital data space that allows us to securely share data so that data are safe but can still be used to really improve, the patient outcome, if not for the individual patient, then for other patients who may encounter a similar scenario in the future. So structural elements on various different ways, from on various different levels, ranging from IT infrastructure to legal infrastructure to coordinative roles to the question of data storage and data exchange, digital infrastructure. That these are all extremely important points. Where, especially in Europe, we really need to become better and improve.
And this is a great case of, you mentioned previously that there's a lot of fragmentation at the national level when in terms of the regulatory requirements, price reimbursement procedures, etc. for also for diagnostics. But this is an area where really the EU can play a larger role, and we've seen that with European Health Data Space. We've also seen that one of the initiatives from European Cancer Plan is establishing this network inspired by the European Reference Networks of Rare Disease, and reference network on cancer genomics to facilitate some of this data sharing and learning. So of course here the EU can play a more of an important role, and it's an important part of it. Antonella, I wanted to kick over to you to maybe talk a bit about what are our recommendations around awareness raising, and why is this important to build awareness raising with decision makers and stakeholders around the value of CGP?
Thank you, Matias, and sorry if I had been cut off before. I have a very unstable Wi-Fi. I hope you can hear me well now.
Yes,
But before getting into the recommendations, I would like to comment the topic, the question that was made before, and the comments that were made, because I believe that yes, there is a problem with the reimbursement issues. So it is important that the genomic testing is approved, reimbursed throughout the regulatory system in the countries. But there are issues that go in parallel and sometimes deeper than that. At Cancer Patients Europe, we have looked at one specific biomarker test, and one specific breast metastatic mutation that is ESR1. And we have noticed across Europe a misalignment between the diagnostic test available and reimbursed and the treatment available and reimbursed, and vice versa. So there are countries where the treatment is available and reimbursed, and the diagnostic, so the precision oncology treatment is reimbursed and available, but then the diagnostic test is not. Or vice versa. So this misalignment is a problem and creates frustration, inequalities, and all that. Then we also noticed another problem. So when sometimes and often when the treatment, the diagnostic test is available and reimbursed, the healthcare professionals, the oncologists, do not prescribe, do not even mention and I can mention this project that we did, the My Cancer, My Concern, where we wanted to assess the uptake of a specific genomic test for breast cancer in countries where this test is available and reimbursed. So we looked at Germany, Italy, Spain, France, and the UK. And in those 5 countries, 4 out of 5 oncologists did not mention to breast cancer women for a specific mutation for which this test is available and reimbursed. 4 out of 5 women were not told by their oncologist that the genomic test was an option. So for us, this means that potentially 4 out of 5 women took chemotherapy without any benefit, only the side effects. Can you imagine the costs, not only on the patients and their families, but also the healthcare system, because the side effects come with an additional use of the healthcare system. So this is a problem to us. And so this is why now I come to the recommendations. So this is why we need to overcome inequalities. We need to speak more with policymakers. And I want also to mention, before getting specifically into the recommendations, the inequalities across Europe, because there are huge inequalities. So now we have heard a lot about the benefits. So there are I mean, for patients, there are no doubts about the importance of CGP and the relevance for them. But the access to a broad molecular diagnostics still remains inconsistent and limited across Europe. And this creates inequalities that we cannot ignore. There is a problem of laboratory capability. For instance, in Eastern European countries, including Bulgaria, Romania, Slovakia, just to mention a few, less than 75% of laboratories have the capability to perform NGS. While in other countries, like Denmark, France, Germany, UK, this capability is up to 100%. But there is also a problem with the utilization, as I mentioned, of these tests. And this utilization rate varies significantly across Europe. So there are countries like Denmark, where the uptake is up to 75%, France 21%, Germany 12%, UK 9%, and we have Italy and Spain, so not Eastern European countries. Here we have Italy and Spain, where the uptake is as low as 2%. So in this scenario, we recommend it's very important that we speak with policymakers. So it is important that we engage policymakers on the value of CGP compared to other diagnostic technologies. And we understand that there might be difficulties faced by policymakers in evaluating different diagnostic technologies. So it is important that clear evaluation processes for new diagnostic technologies are in place. Then we have the evidence about the value and the benefits to the patients, the healthcare system. But we now need to work more on building the capabilities, and awareness, especially among patients and the general public, for instance, in our specific case, for patients, it would be very important to have patients empowered to share decision-making, so to bring the issue of the genomic test up with the discussion while discussing with their oncologists. So it's important to raise awareness through raising awareness campaigns among patients and the general populations, but it is also important to educate, I could say, healthcare professionals on how to utilize CGP and understand the clinical data report. And I stop here, Matias, I give you the floor to you.
No, thank you so much, and apologies for technical difficulties. I mean, this is really great point. So as much as it is about reimbursement, and we have recommendations on this, right? That reimbursement needs to be placed. This is clear. Then without reimbursement, there's no access. But even when it is reimbursed, there needs to be an awareness also for patients that this is available. So you're able to access it. 4 out of 5 not being informed. I think that's everyone can agree that it's way too high. And of course, we need to also make decision makers aware that this is not acceptable, and because if they're not aware that this is happening, then nothing can be done. So really great work collecting that data and digging up those numbers. We have also some recommendations here on the need to increase collaboration between decision makers and stakeholders. Rather than going through all of them, let's invite everyone to have a look at those on our website. Feel free to download the paper. I want to maybe just for 2 minutes, Albrecht, do you have a few? I want to give the floor to you, Albrecht, to speak a bit about. So we've heard about the benefits, we heard about some solutions to implement this in Europe, but it's currently already being implemented in places such as in Germany. So what are some of your experiences with the implementation of CGP from Germany, Albrecht?
Yeah, thank you. Before mentioning a few experiences, I would like to briefly get back to what Antonella brought up, and I fully concur with her, and do think that a lot of these inequality issues are related to very different and sometimes also intransparent decision making of the various HTA bodies in terms of the question of the drug being reimbursed, the test being reimbursed, both at which level, and so on and so forth. And the other point, certainly also, which Antonella made, the question of education, teaching, training in a very fast-moving environment, right? So the field is growing at unprecedented speed in many ways, and so it is also an obligation of the clinical partner, but actually also of the pathologists and other diagnostic institutions to keep up with that pace, meaning attending international conferences on a regular basis, understanding the trial landscape, understanding the technical landscape of testing, understanding new biomarker scenarios evolving, and that also helps to close and bridge some of the gaps in terms of creating a common language and also a knowledge basis upon which one can interact more meaningfully. Now, with respect to best practices, so Paul and I are working together in various projects over almost a decade, and I think that brings me to the first point. It doesn't make any sense to reinvent the wheel everywhere again and again and all over again, and running into the same traps and making the same mistakes, rather than building networks from which you can benefit because someone has experienced already a certain technical scenario that you want to avoid, and then it probably does make sense to hear about this and see how you can advance quickly. So building networks to advance quickly, but also to establish guidelines and certain standards is very, very, very critical, and that goes beyond the individual institution. The other aspect that I already brought up is the thing of some form of centralization. By that, I am meaning, and I understand that an institution that performs such tests need to have a critical mass of expertise, people, infrastructure that we touched on, in order to be innovative, but also to provide such tests in a scalable manner and at fast turnaround times. That pushes an entire field, I believe, towards a certain degree of centralization. Now, do I believe that one institution running the entire show in a certain country will help a lot? I doubt this personally, because if you think that from a patient perspective, you still need local regional networks, right? So there may be the patient who is being treated locally with his or her practitioner oncologist, and the test is being carried out, at some major center nearby. But there still needs to be some interaction where people know each other, where the patient knows the oncologist knows the institution where the assay is being performed, where you can have direct interactions in terms of, is the test suitable? Is the material suitable? Do we need to change and tweak certain aspects in order to make it work? How can we build up logistics? So a whole range of different, quite complex issues, actually. And therefore, I think that some degree of centralization is critical, but it shouldn't probably lead to a scenario where only one institution in a certain country is doing the entire testing for the points that I was mentioning. And then maybe
Albrecht, I know we're on time. In fact, we're 1 minute over. So if you tell me the very final thing, and then I want to just quickly wrap up. But please, the third lesson, I think, in addition to building network centralization.
Yeah. So very last point. Many thanks. Very last point. It is important that institutions know their assay and can communicate the assay and what it can do and what it actually cannot do precisely to both the oncologist as well as the patient as well. So knowing the inner workings of a test is quite a substantial aspect as well. I'll leave it to that and hand over back to you. Thank you.
Thank you so much, Albrecht, for bringing those important experiences, and like you said, years of experience working together. It's a shame Paul could not join us today, but I want to thank you so much, Professor Albrecht, Stenzinger, Antonella, Cardone from Cancer Patients Europe. Thank you so much for joining us for this discussion today. Thank you to the audience as well. I know there were a few questions still. Maybe we can circle back to them via email. So thank you so much for contributing to the discussion. Please go and visit our website. You can find our recommendations here. You just have to scan the QR code and you'll be taken right there. And perhaps we can have a follow-up webinar where we can discuss a bit more in detail some of these specific points that were raised. I think these specific lessons, the role of centralization versus local delivery, lab capacity, awareness raising as well, digging a bit deeper into what are some of those lessons from the national chapters on engaging conversations on how to reimburse, what to pay for. I saw this question in the chat as well. So we look forward to continuing the conversation. You know where to find us. Thank you so much for tuning in today, and thank you again to Albrecht and Antonella.